So I'm not going to teach you about what AKI is, but obviously today is World Kidney Day, and fact 7, which was the fact from yesterday, is the fact that AKI is really common, and it happens a lot, to people who are in hospital. And more, the more we know about AKIs, the more we realise how serious it is. And we now think that you're more likely to die if you come into hospital with an AKI than if you're having an acute MI. And I think that's really important to say. I very specifically chose Charlie Webster because her story spoke to me when I had recently become the AKI nurse about someone who was so fit and so well and how deathly ill she became. And she spoke earlier about how well she looked. And this is 3 days before she's intubated and ventilated in intensive care. This is at the end of her race to Rio. And you can see that actually she looks well. It's not like the best picture in the world, but you can see that actually she looks like a fit, well, young adult. And I think she was quite right that more and more we think about kidney problems and kidney failure as a disease of the elderly. And we recognise that our elderly patients are at risk, but we quite often forget that our young patients and people like us are also at risk of developing AKIs. And I think one of the problems that we have with AKI alerts is that AKI alerts are generated for a lot of patients now, because we do have a lot of patients who have AKIs. And people just go, oh, it's only an AKI stage 1 or it's only an AKI stage 2. But actually, an AKI stage 1 can look like this. So we do ventilate patients who have AKI stage 1s. We do give patients who have AKI stage 1s dialysis and acute hemofiltration. And I think that was one of the things that I would like to take home as a message about AKI. We're very lucky that we filled in something called the renal registry, where we provide data, and we get something, it's about 3 months in advance, so in March we'll get the data up until December. But this shows you how many patients that we have having AKI stage 1s, 2s and 3s. We do get paediatric patients who have AKIs. They are less common because we have less paediatric patients, but they are more common here because we are a paediatric nephrology centre, so we do have lots of paediatric nephrology patients. And what you can see from that is there were, in 3 months, 1,890 patients that had AKIs. This data is the stage of their AKI when it started. Okay, so 110 patients had AKI stage 3s. That was their AKI when it started. That doesn't mean there was 110 patients in total in those 3 months. What we know is that about 30% of our AKI stage 1s and 2s go on to progress to stage 3s. So we have about something around the region of about 250 patients in a 3-month period of AKI stage 3s. It is more common in females to have an AKI stage 1 or stage 2 than it is in men. So because it's World Kidney Day, that is in adults, I should say. That is something that we should think about. It is more common. More young women are affected than young men. AKI stage 3s, it is more male than female. The average age for AKI stage 1, stage 2s and stage 3s is 73, 72 for stage 3s. But actually, on this list is patients as young as 18 and as old as 104. There was one that was 116, but that I think was a skewed bit of data from ITU. I'm blaming intensive care because they put everybody was born in 1900, which is making them all like 118 now. They need to move to like 2000 or something. But there are more women than men affected for AKI stage 1, stage 2s and stage 3 stage 2s. One of my first jobs when I joined the team was to try and make our AKI stage 3 care better. And in 2012, we took part in a NHS England review of AKI stage 3 care. And what we found was, actually, we did quite well at some things. So most of the patients were seen within 12 hours, which is really important because an AKI stage 3 is a life-threatening medical emergency. These patients have a mortality, as Dr. Armstrong said earlier, of about 36%, and that's on that hospital admission. So they are more likely to die than most of your other patients. So it's really important that they're seen by the right people at the right time. And 45% of patients had their urine dipped. And we've heard already about how important proteinuria is and hematuria in patients with renal disease. So it's really important for them to have urine dips. Only 36% of patients who needed a renal ultrasound got one, which means there was a huge number of patients who needed renal ultrasound to rule out obstructive causes, things like those obstructive pyelonephritis patients who have renal stones causing hydronephrosis. At medication review, we were excellent, far pharmacology. Pharmacy were on it. They were on it from day one. As soon as the NC-POD guidelines came out and medication review was on that, they changed practice quite quickly. What we did know from the 2012 data was that at UHS we had a longer length of stay than national average. At most things we were better than the national average, but our patients stayed in hospital longer, and obviously that has a cost implication for us. We also had a slightly above average mortality rate for those patients. We did some work in 2015 and 2016, and the AKI alerts came on in April 2015, and those things generally got better. Urinalysis dipping in documentation did not get better, but our length of stay did go down. We did lots to make it better, but it was all very much patient focused. Part of my job is to go around and see the AKI stage 3s, so they all should get a senior review. No one's been seen today. We've sent the renal reg today. So they all get seen by somebody who knows and understands what an AKI is and what can cause it. We wanted to improve the diagnosis of AKI, and I don't mean that the patient had an AKI, I mean the underlying cause. So is it a pre-renal cause, is it post-renal, or is it a intrinsic? Everybody assumes that people coming into hospital who have got diarrhoea and vomiting have got diarrhoea and vomiting, and that's caused their AKI. And we forget to dip their urine and realise that actually they've got diarrhoea and vomiting because they have an AKI. That's not the cause, that's the effect. So things like carrying out renal ultrasounds for patients who are suspected of obstructed or have pyelonephritis within 6 hours as per NICE guidelines, making sure we dip and document those urinalyses. That's quite hard to say, isn't it, at the end of the day? Education. Those of you who work here have probably seen me and have probably heard me talk about AKI. I will talk to you till I'm blue in the face. I will talk all day about AKIs to try and make everybody look after those patients better, have a better awareness of what it means for those patients to be hydrated, better documentation of fluid balance charts, so that we can try and make their care better. And we looked very specifically at what patients were at risk. So we knew that actually quite a lot of trauma and orthopaedic patients got AKIs in the initial post-op phase that were out of keeping for their age and other diagnosis. So we did lots of work. There's an AKI working group which I'm part of, and that's a multifactorial, multidisciplinary group with lots of people. I can't tell you how much medication I did. Oh my God, I do so much education. And I'm happy to do it, and I would do it all day long if I could. I'm part of the medication safety group, and we look at AKI incidents where patients have had drugs that have gone on to cause AKIs very specifically. We looked at elective hip and knee surgery. Like I said, those patients were getting AKIs not in keeping with how unwell they were pre-operatively. With Jackie Prieto, who's here. Put your hand up and wave. We've done lots of work to try and make their pathways better to reduce the number of AKIs. I have to say I haven't seen a patient in trauma and orthopaedics who's had an elective hip and knee surgery for over a year who's got an AKI stage 3. So although we haven't fully researched how well it's worked, it obviously is making it better. We've done audits about how to do renal ultrasounds and how they're requested and when they're done. And what we found is actually lots of renal ultrasound requesting is a reflex. The patient gets an AKI, do an ultrasound. And actually, most of the patients who get them don't need them, and most of the patients who do need them don't get them. Like when Mr. Samani was here earlier talking and saying, Kristen said about getting an ultrasound scan for those patients who NICE guidelines are, if you have an AKI and you suspect that they're obstructed, they get an ultrasound within 6 hours. It doesn't say tomorrow, it doesn't say on Monday, it says within 6 hours. All hospitals that provide AKI care should be able to provide that, and we certainly do. But one of the things is people go, oh, well, they can wait till tomorrow. But by tomorrow, you have to wait till then they do it, and then you get someone to review it, and then you get someone to come, and then there's no urologist on site who can do it, and no interventional radiologist to stent them, and it all takes time. Those patients, NICE guidelines are there for a reason. They're there to make patients safe. So if your patient has an AKI and you think they might be obstructed, they should get an ultrasound within 6 hours. And we've done some audit work and we've shown that that's got better. We're requesting less AKIs, less ultrasounds that we don't need, and we are requesting more that we do. I work as well as part of the Wessex Patient Safety Collaborative, and that's looking at what other hospitals are doing and other hospitals are doing well. We started doing the nutrition and hydration assessment and charts, which is an idea that came out of a Wessex Patient Safety Collaborative meeting. And we do loads of audits, including a urinalysis audit. I'm really pleased to say that urinalysis is up to 65%, which means 65% of all the patients that I look at have had their urine dipped and documented. I know that almost all of them have had their urine dipped. It's just documentation that's poor. It's not dipping. I know, like, nurses and healthcare assistants are obsessed about dipping wee. We dip it all the time. I'm pretty sure if I gave you all dipsticks to take home, you would dip your own wee. I'm pretty sure you would, because we do. It's just something we do, but we're really bad at writing it down. We're really good at writing it on your glove, on a bit of paper, on your handover sheet that you put in your pocket, and then take home, and then you get home and go, oh, it's all right because it was negative. But what I'm trying to promote is, with lots of teaching, is that doing a negative urine dip is just as important as doing a positive one. And actually, Mr. Samani was talking earlier about looking for UTIs. Thank you. But actually, one of the things we need to make sure we do is document protein in blood. And lots of people go, there's no leukocytes, there's no nitrates, there's no ketones. It's fine. And I didn't miss an opportunity to give you a fluid balance chart bag. Please fill in fluid balance charts. There's fluid balance charts, pens in the pack, fluid balance charts, bags. It's the documentation of fluid balance and understanding how well hydrated our patients are that can prevent preventable AKIs in hospital. And as Mr. Samani said, you can prevent getting yourselves UTIs and kidney stones by making sure you're well hydrated. So documenting makes it a big difference. Our recent data shows that we are much better. Our average length of stay for patients with an AKI stage 3 is now 10 days. So a big improvement on what we were, which is 16 days, and actually better than national average. We also have a much better mortality. So if you come to UHS with an AKI stage 3, you are less likely to die within 30 days or at hospital discharge. I'm quite proud of that because I think that's quite a good thing. And we saved quite a lot of bed days, which saves quite a lot of money. So what are we going to do now? That's not supposed to be nothing. Just carry on doing exactly the same, because hosting days like today where we get to talk about AKIs, where you get to hear about people who have experience of AKI and they can talk about their lived experience, I think makes a massive difference. Doing fluid balance documentation, which will be coming on electronically very soon. And dipping urine. I can't say that enough. Does anyone have any questions? Oh, you do, yes.
Do you think it was the documentation of urinalysis that improved, or the actual administration of urinalysis?
So I think the documentation is definitely improved. I think that there is more urinalysis being done, but not a lot more. So I don't think it's a lot better. I think it's just better documentation. I think they were already doing it and just not writing it down, because lots of people don't write down a negative result. So, yeah, and it's so important. Any other questions? I'm very aware it's the end of the day. Yeah? Yeah?
Could we have a bit that says urinalysis, LED or positive? That would make life so much easier, and the documentation would be like that.
Yeah, probably. We probably could actually. That's a really good idea.
Another thing is, I feel like patients are missing some of the ultrasounds, for example, because they go downstairs for other procedures or for other complementary exams, and the tele-tracking, the picturing, it's not actually communicating.
Oh, okay.
They come up to pick the patient up, and the patient is downstairs, so it can actually be very quickly to go to that.
Yeah. Okay. That's something we can definitely look at. You had a question? When we have electronic obs here, and so we're moving across completely to electronic observations, there is a urinalysis section in our electronic obs, because we're going to be paperless by December of this year, allegedly. See, the people who work here did laugh at that. That was the. So technically there'll be nowhere to document anymore after December, so it should all go onto the electronic chart. So it is on the electronic observation chart. It's just not very well used there. And ITU, which is completely paperless already, don't use it massively well for documentation, and I think they dip all their patients. So, is there any other questions?
Okay, so just very, very fine. I know everyone's really eager to go. We've only overrun by a few minutes, but I just want to say thank you very much for coming today. I think we've hopefully managed to get the message across, and I think this slide just highlights the main facts related to World Kidney Day theme this year. So I think we won't go through all these again because we've put them all in the talks. This is another really important message. We've talked a lot about, you know, facts and figures and AKI, CKD. We're also obliged on World Kidney Day to tell you what you can hopefully do to prevent it. So all the sensible things: keep fit and active, don't smoke, be careful of the medications you take, maintain healthy fluids, eat healthy, monitor your blood pressure. You all know that, but we all need to do it. This is the big push, and then we have to give this push. So please remember, we've had lots of information about the importance of transplantation. We've had patients telling us how it's changed their life. 2 patients in the audience who've had kidney transplants. So just reconsider, if you're not an organ donor, please just think about signing up. And we should have had some cards today. In fact, we will make sure we have those next year. And just to conclude, that the focus of World Kidney Day was to make sure we can aim to provide affordable and equitable access to health education, healthcare and prevention for kidney diseases for women and girls in the world. So happy International Women's Day, and thanks again to Becky for organising a really good day. A lot's going on in the background.